This is week 10 in class presentation covering chapter 10 and 11, concepts of emergency and trauma nursing and care of patients with common environmental emergencies. The book does a good job explaining the emergency room nurse, but I wanted to take a minute to kind of compare them to the ICU nurse and their focus. So when we think about the ICU nurse, their work environment is controlled, focused, and continuous patient monitoring, whereas that ER nurse is fast-paced, high-intensity, managing immediate critical care. So their environment couldn't be much different. For patient conditions, the patient in the ICU are long-term, life-threatening conditions that require constant attention. In the ER, the patients are acute emergencies needing immediate stabilization, and they could be from the gamut of a very small issue up into life-stabilizing issues like a near-death experience. The responsibilities for the ICU nurse are to manage ventilation, IVs, and advanced life support equipment, very same to the ER, except for they're performing those quick triages and they're stabilizing and then getting them off to the next place. In certifications, most ICU nurses hold a CCRN or other critical care certification. In the ER, they hold TNCC or trauma care nursing, ACLS, and PALS. Skills, both have critical thinking, in-depth patient care, and end-of-life support. The difference being that in the ER, they make a lot of decisions in regards to triage. The patient focus for the ICU nurse is on details, long-term care and monitoring, and the ER nurse is immediate diagnostic, rapid treatment, and stabilization so that they can get to the next environment. So you'll often hear people complain about their time in the ER. I just kind of wanted to bring up a few statistics for you. So the first thing is, do you know when to go for care? A lot of people go to the emergency room when it's not an emergency, and unfortunately that takes away beds and space for patients who are having an emergency. So for an emergency, they should call 911, and this is if it's a life-threatening injury. And for non-emergencies, you could see your primary care physician, you could go to an urgent care, have a virtual care appointment are now becoming more popular. The important statistic to remember here is that 141.4 million people go to see the emergency department annually. 13.9 of those arrive by an ambulance, and 31.5% of ED arrivals are age 65 or older. So we know that there's a lot of comorbidities going on there. 11.2 million ED visits per year result in the hospital admissions. So just keeping in mind that these people are overtaxed. So we have to be patient and realize that there's going to be triaging involved. So homelessness is a common topic that you'll hear for our patients in the ER. They often come in related to comorbidities, the lack of a primary care physician, lack of insurance, knowing that they will be seen. Obviously, we have a homeless population in Michigan. As an average, it's an overall percentage of 2%. It varies based on different areas within Michigan, but the important thing to remember is that there is a housing disparity among people and their housing wage based on what houses are costing them. When you have a patient coming in and they admit to you that they are homeless, it's important that we listen to the patient's concerns and needs so we know how we can better assist and prevent readmission. This is a great time to get social work involved and try to assist them with housing needs, or at least some kind of a plan so that they're not coming back for readmission because we didn't address one of their bigger issues. The book talks a lot about staff safety, but I want to address this in a different form. Obviously, when you're working in the emergency department, you're one of the first people that these patients see before they even hit the floor. So there's a lot of intense emotions at that time, which puts the nurse and healthcare worker at a significant risk for job-related violence. They say that while under 20% of all workplace injuries happen to healthcare workers suffer from 50% of all assaults. So it's important not only to assess your environment for contagions like COVID and meningitis, you also want to assess if your patient's going to become violent. So obviously taking on special training like a de-escalation training is super important, making sure that we're always supporting our teammates. We want to plan to protect. So if we know that a patient has been violent in the past, we often put that in their charts, and we make sure that we're not the only one in the room with that patient. If you see it, we report it, and we advocate for protective legislation for our nurses. What's happening when a patient's admitted through the ER is the check-in process, which could be ambulance, could be that they came in as a walk-in or a general practitioner referral. They come in, they're checked in through triage. If they were brought in by ambulance, a lot of times there's a handoff between the two caregivers, and then we go through the investigation and treatment with our patients. Now, based on that triage time, there may be some waiting, and that's where a lot of times these patients become very frustrated. There's a lack of understanding as to why some patients are being seen before other patients. So it's always important that we let them know that if you're not being rushed right back, then chances are there's someone who's getting help who needs more help than you. And that may not sound like a bad thing, but it's actually a good thing. So keeping in mind that we do our resuscitations first, and then our majors, like our traumas, a risk of limb, and then we go to our minors, and then we go to our streamlines, the ones that could have probably gone to an urgent care and been okay. A lot of times our resuscitations and our majors, some of our minors will be hospitalized, some may be sent home if they are stabilized fast enough, and then we have those who could have been to urgent care who may be redirected if we are full. So safety factors that you might see within an emergency department, some that are patient related, are the acuity and emergent conditions that keep getting worse every year. The age extremes, they see patients all the way from newborn all the way till as old as you can get. The communication barriers, they see all lengths of people, so they could see someone who may not speak our language, and having an interpreter may be more challenging in the fast-paced and loud ED environment. Vague and atypical complaints. The patient may come in and say that they have a headache when in actuality they have a brain bleed going on. So getting them to clarify what that may look like. An undifferentiated presentation. So if you have someone with a gallbladder attack, they may come in complaining of shoulder pain. So just trying to figure out what is the real cause of their pain. Cognitive impairment. Patients who have stroke, a lot of times can have some verbal discrepancies of what they're trying to say, so that could be an issue for a nurse trying to do that assessment. A lot of people come in with multiple comorbidities, so that complex medical condition really kind of comes into play here. They may have a lack of knowledge of medical problems and their medications, so they may come in and tell the nurse that they take 2 pills for their blood pressure and not know what they are. For provider-related safety factors, there's always new doctors on, so experience can be an issue. Because it's shift work, there can be fatigue. There can be cognitive errors when people are tired. We can miss test results. There can be procedural errors. There can be policy deviations. And then the transitioning care can be hard, especially in outlier hospitals, if we don't have those specialties in the area. Environment and system-related issues can be inadequate staffing, can be inexperienced staffing, can be teamwork and communication problems, can be overcrowding, boarding of admitted patients, lack of equipment or equipment failures, reliability of consultation services, inadequate consultation services, lack of complete medical records, or difficulty using healthcare that's electronic or order entry systems. Something that we have been seeing that is helpful for the system-related issues is the telehealth, letting specialists come into outlier hospitals. Another thing that ER nurses see is domestic violence. We can see this in all parts of the hospital, but these patients will come into the ED often with vague complaints to get assistance. So in Michigan, 70 every month on average, 70 women are shot and killed by an intimate partner. Domestic violence situations where a firearm is present increase the risk of homicide by 500%. In Michigan, 65% of women killed by the intimate partner were killed by a firearm. and 5 times access to a gun makes it 5 times more likely the abused partner will kill the female victim. And then there's a number in the event that you know of anyone who's suffering from domestic violence. So ER nurses deal with a lot of different issues. Another one is rape and assault. Things that the ER nurse brings to the table will be little to no training on how to work with a victim of sexual assault. They may be unaware of legislative changes. They perform fewer vaginal exams, and they have no advanced training unless being provided by the ER. They may be asked to care for other patients while they're caring for a patient of rape or assault, and they're required of physician involvement in the exam. So this is where it's great to have a SANE nurse available, and a SANE nurse is a specialized trained nurse who has had patient-centered care of 80 plus hours with rape and assault victims. They should be knowledgeable in the legislation changes in the area. They perform multiple exams per year. They provide advanced training opportunities, so these nurses have the additional training needed to better handle rape and assault victims. They have one-on-one patient care. They're not seeing any other patients while they're there, and they function independently when performing any kind of sex and rape kit on the patient. Human trafficking is another issue that a ER nurse may see. These patients come in with STIs, injuries of unknown origin, unplanned pregnancies that they're being treated for. So the human trafficking data in the area in 2020, there was 845 total contacts, 295 total cases, and 258 calls from victims or survivors. We do have a human trafficking hotline that can be called, but the important thing to remember here is whenever there is a potential for human trafficking, we want to get the patient away from the domineering partner that's with them, or whoever they say they are, and try to ask them if they feel safe where they are and if they're able to quit their job if need be. Just asking these very vague questions in order to truly assess whether or not this patient is a human trafficking patient or not. And then, of course, reporting that. So the primary function of an emergency room is to perform triage, which is quickly identifying and treating those patients who are at the greatest risk. So if we see someone who's red or an emergency, these are the patients who, if I don't do something right now, they're going to die. Urgent is, we have 10 to 20 minutes where we could try to help them, and that would give us a chance to handle our emergency. Our delayed ones are definitely need some help, definitely have a break or something, but you would be okay for a little while I handled my immediate or urgent patients prior to getting to you. And then our deceased are our sad ones. Those are the ones where our patient is not going to make it, and so we have to make the hard choice of letting them go in order to care for the patients who we can help. Just to break that down a little further, the level 1 are our resuscitations, our patients you have to see right now. The level 2 are our emergencies, have to be seen within that 15-minute window. Level 3 are urgent, within 30 minutes. Level 4, less urgent, within 60. And then the level 5 are the non-urgencies who could wait up to 2 hours and be okay. Again, that black level is the level where we've determined that we're not going to be able to save them, and resuscitation, any resuscitation would be futile. In the event of a mass casualty, they will utilize tags on the patient to identify their need and their basic information. These are used in mass casualties where you have multiple patients coming in at the same time and our triage is overwhelmed. So anyone can fill out these tags for our patient and we can get them the help they need as quickly as possible. Two issues I wanted to talk about as far as death in the ER. If a death is suspicious in nature, an example, a homicide, suicide, or trauma, all belongings must be locked away and tubes, lines, and devices are left in for the medical examiner to assess. We do this to make sure that everything we did to try to save that patient can be assessed properly and that there is no foul play. Also, it any kind of things that they come in with are evidence. So making sure that we keep all of that for the medical examiner and the police to investigate helps with the investigation. When we look at the room on the left, that is a standard ER room. The room on the right, much more chaotic, but in dealing with the trauma. It's important to remember that we are caring for people every day, and sometimes that can be very overwhelming for nurses. We can all become a little callous to the idea of what we're doing, but it's also okay in the event that this gets to be too much that you reach out for help. There are different levels to trauma centers. Level 1 is a regional resource facility that provides leadership and total collaborative care from preventative through rehabilitation. It usually are large teaching hospitals, and they are in dense populated areas. A level 2 usually is a community hospital that can provide care to vast majority of injured patients. The level 3 is usually smaller, like a rural hospital that has a focus on initial injury stabilization and patient transfer if necessary. And then the level 4 is usually located in a rural or remote setting, such as a ski area, where they stabilize and they ship as soon as they can. So there have been several studies conducted on reasons for nurse burnout. The majority state that the reason they felt burnout is related to low staffing, but there's also a huge contingency on emotional exhaustion and the workload. Other things could be no respect, physical exhaustion, low pay, crisis during COVID, less breaks, and then bullying or abuse. So when we think about some of these different reasons for burnout, we have to look at why we feel that way. So the source of the stress is the job design and workload. So dealing with death and dying and that ambiguity of it. Interpersonal relationships at work, the conflict with other people, relationships with patients and their families, inadequate preparation for dealing with the emotional needs of families. So like when we have a patient who has a code in the ER, bringing that family into that to see the code, that can be really unsettling. And then realizing that when that patient passes away, that family member is now our patient that we're caring for, helping through a really emotional time. That can be a lot for everyone to deal with. Work organization and management of work, lack of staff support, feeling that RN shortage and lack of resources when you're feeling overwhelmed. The technical aspects of nursing, concerns about the treatment and patient care, how to make sure that we're utilizing everything that's possible for our patients. And then just realizing that there's some personal stressors in nursing, like concerns about technical knowledge and skills, feeling like you're enough to care for these patients in these desolate times. The biggest research out there about how to prevent nurse burnout is doing that physical self-care, the emotional self-care, making the most of your time off, acknowledging it when you've had a rough day, taking that time and really sitting down and assessing how you're feeling and why you're feeling that way. And if there really was anything else you could have done, talk it out with a friend. Obviously, HIPAA friendly talking, not talking about specific names or anything, but just talking about what happened and how it made you feel, getting enough sleep, exercise, eating healthy, making time for fun, and then seeking out trained professionals if you are struggling, and making sure that you continue on with your professional development so that you are giving the best care possible. Now we'll go on to some of our audience response system questions. Question 1 is, which client will the emergency nurse triage as the priority? A client with displaced ankle fracture and a mild laceration, a client with vomiting and intermittent flank pain, a client with profound weakness and a 102 fever, or a client with sweating, jaw pain, and pain in the left arm? The answer is D, because we're thinking that this patient is having a myocardial infarction. That would put them as our emergent. While performing a history, a client becomes unconscious. Which action will the nurse take as a priority? Obtain the vital signs, assess the airway, contact the ED physician, or evaluate the patient's level of consciousness? Correct answer here is C. The primary servo organizes the approach to the patient so that the immediate threats of life are rapidly identified and effectively managed. The primary servo is based on the standard of ABC mnemonics, so airway, breathing, circulation, disability, and exposure. The highest priority intervention is to establish a patient airway. All other actions can be completed after the airway is established. A nurse is caring for a client who has been seen in the ED multiple times recently for sexually transmitted infections. There are bruises in various stages of healing on the legs. When the client's partner goes for coffee, what is the priority nursing action? It says look for a tattoo or branding mark, complete a psychosocial assessment, ask does anyone you know make you feel unsafe, or follow agency policies to contact local authorities. Correct answer is C. After establishing a therapeutic relationship, the nurse should ask the client if they feel unsafe as soon as the partner leaves to get coffee. It is important to obtain information quickly while the client is alone before the partner returns so that the client can freely express concerns. The nurse can then complete the other portion of the assessment and report if indicated to the authorities. To our next chapter, which is Chapter 11, Care of Patients with Common Environmental Emergencies. First one we talk about is heat exhaustion. These signs and symptoms of this is headache, fatigue, weakness, skin moist or sweating, decreased blood pressure, definitely some orthostatic hypotension, increased pulse, could have some increase in anxiety and confusion. Management is salt and water replacement and rest. We want to make sure that we are not giving them salt tablets and not just giving them water, which can further create that electrolyte imbalance. The cause of this is a decreased fluid intake, an increase in activity and heat exposure. That body temp has to be less than that 38.8 or that 102 degrees Fahrenheit. If heat exhaustion isn't managed properly, that will lead to heat stroke. We'll see an increase in anxiety and confusion. The skin can be hot and dry. There's sodium and potassium depletion. There's impaired sweating, which can lead to some listlessness. If our patient starts having cerebral edema, which is common with heat stroke, they could have seizures, delirium, and coma. This is an increase in the body temperature of greater than 105. It's increased pulse and respiratory rate. They are hypotensive. Management is cooling, rest, and fluid and electrolyte support. To go in the completely opposite direction, we could talk about hypothermia. With hypothermia, there is mild, moderate, severe cases all the way up to death. If the patient's temperature gets to 95 degrees Fahrenheit, we start seeing some shivering. They still have a normal mental status. If they start dropping 82 to 90, we start seeing an altered mental status and they are not shivering as much. Temperature drops to 75 to 82 degrees, we're starting to see the patient be unconscious. And when they dropped below 75, there's a apparent death. Resuscitation might be possible. If our patient drops below 48 degrees, there's death by irreversible hypothermia, and resuscitation is often impossible. So our first warning signs of hypothermia are obviously shivering. We start seeing some blue tinge to the skin. In these events, it's good to get the patient inside and start warming them. If they're wet, we want to make sure that we get them dry. Being careful if we notice any signs of skin damage, that we're very cautious while we're approaching to apply dry towels and cloth to that. Hypothermia can be accompanied by frostbite. We start with frost nip, which is the milder form. The skin turns red and cold. Numbness, burning, itching, and prickling sensation can happen. This is reversible. When we get to the superficial frostbite, the skin turns pale and blue from red. It's hard and frozen skin, warm and swollen skin, and pain and numbness. With the deep frostbite, we're seeing the severe form. The skin turns white to bluish gray and looks splotchy, numbness, lots of sensation of pain, and blood-filled blisters are seen. During these last stages, the first step is to rewarm once they are safe, but this is painful. So if in the hospital, they want to be having pain medications first. those blisters often will end up popping, and depending on the level of frostbite will be the amount of skin damage that is complete. We are supposed to rewarm them, and that can be very painful. So when we're doing these things, we have to make sure that we're not touching anything with the skin that is frostbitten. When you're reading the section on snake bites, you might have been thinking to yourself that there aren't any venomous snakes in Michigan, but there are. Severe coagulopathy after a Misogynah rattlesnake bite is the biggest concern. So what happens is we have Misogynah rattlesnakes in Michigan, and if they bite you, they can actually cause your blood to not be able to clot, and you actually will bleed into the area, which can cause compartment syndrome. Snake bite do's and don'ts. Again, we don't apply a tourniquet anymore. You don't cut open the area on your own. You don't try your own herbal supplementations, and you don't try to suck the venom out of people. You do get away from the snake. You do call 911. You do elevate the extremity that was bitten, and you do take them to the hospital because we can hope for anti-venom and other therapeutic reliefs to the snake bite. Arthropods is a big chapter for us, but spiders that are highly venomous in Michigan are the southern black widow, the northern black widow, and the brown recluse. In the event of being bitten by one of these spiders, they can cause a lot of tissue damage. The other thing that they can do is they can create a lot of swelling in the area, so getting to the hospital if you've been bitten by one of these spiders is very important. It also talks about mosquitoes, which can cause welts and pruritus, fleas, which can cause red and pruritic areas around the puncture, usually grouped bites, sugars, which can cause bites all over the skin, and then the deer ticks we talked about at quite a length in regards to the fact that they're a vector for the Lyme's disease. Bed bugs can also cause biting. Usually they are in the folds, armpits, inside fingers. So when you see these kind of bites, kind of knowing what caused them and how we can treat them. The biggest one we talk about as far as arthropods are the bee stings, and knowing that people who have sustained more than 50 need to be observed in an emergency setting for several hours to monitor the development of a toxic venom effect. You want to be sure that prepared for possibility of the patient needing to have more of it administered for the epinephrine, and they may need to be admitted to a critical care unit just to make sure that they are on the mend. Teaching your patient how to use an epinephrine autoinjector is super important when they have an allergy to things such as bee venom. And in our area, it's quite prevalent. So the odds of being struck by lightning seem quite odd. Often we joke about you have a better chance of being struck by lightning, but I will tell you that the average yearly reported number for the United States is 27 deaths, 243 injuries, and that's a total of 270 total hits. More importantly, I wanted to kind of discuss the Lakenburg figure. This is that branching pattern that appears on the skin and are formed due to the electrical discharge that occurs during a lightning strike. They can also be referred to as the Lakenburg scars or the keranographic markings, and they're typically fade within a few days, but it looks like lightning coming down the skin. It's actually caused by the skin capillaries being burst. So altitude-related illness is a physiologic change. It's because our body is not adapting well to the decrease in oxygenation. Symptoms are headache, loss of appetite, disturbed sleep, and a lot of times you'll see some dizziness and some inability to concentrate. The risk factors are the speed at which someone is ascending. Also, for people who have not had great endurance with physical activity and a lack of acclimation. So they're not taking stops on their journey in order to acclimate. For more severe symptoms, we'll see high altitude pulmonary edema and high altitude cerebral edema. With those cases, we have to get them down. Best intervention is to get to a lower altitude. We see these as a gradual ascent to prevent. We're making sure that they're keeping hydrated, taking the certain medications that can assist with treatment of this, and then we're making sure that we descend to a lower altitude if we're having any of these altitude-related illnesses. It does state in the book that if you have HAPE or HACE, you have to be hospitalized in order to get proper treatment. When you just have altitude sickness, a lot of times that's recoverable once you get to a lower altitude. It's a big issue around Michigan. Great Lakes drownings in 2019 showed Lake Michigan had 22 drownings, Lake Erie 10, Lake Ontario 6, Lake Huron 5, and Lake Superior 2. Drowning is the #1 reason for unintentional injury or death among children between the ages of 1 and 14 years of age. So the biggest thing to take away from this is prevention is key. You never want to swim alone. You don't want to swim under the influence of drugs or alcohol. You don't want to have a person swimming who doesn't know how to swim by themselves. You want to make sure there's somebody with CPR certification around, and that if you have younger swimmers with you, that there's vigilant supervision so that they're not just being out there in the water with no one watching them. Next will be our Chapter 11 Audience Response System questions. So the nurse is caring for a client who is camping with friends. The client woke up vomiting and severe pain on their right lower leg, which is swollen and red. For which condition would the nurse assess as the priority? So we have a snake bite, heat exhaustion, altitude sickness, or a brown recluse spider bite. The answer for this would be a snake bite. The effects of a snake bite include weakness, nausea, vomiting, hypotension, seizures, coagulopathy, severe pain, and localized tissue swelling or redness. The brown recluse spider produces an ulceration lesion. Leg pain is not characterized as altitude sickness or heat exhaustion. Question 2. A client at the urgent care reports being stung by an unseen insect. The electronic health record indicates a history of allergies to bee stings, so which nursing action is appropriate? Remove the stinger, apply ice to the sting site, give oxygen, and prepare to administer acetaminophen IV, prepare to administer epinephrine IM and oral Benadryl, or establish an IV infusion for normal saline and apply heat to the stung site. So the correct answer for this one is C. Once in the clinical setting, clients will react to bee and wasp stings, need epinephrine administration IM. An antihistamine such as a Benadryl or a chlorpheniramine is also given. Oxygen administration and continuous cardiac and blood pressure monitoring are also initiated. The nurse will also establish an IV infusion with normal saline solution to support the blood pressure. Advanced life support drugs and equipment should be immediately available. It's not appropriate to remove the stinger and apply ice, or to give oxygen and administer Tylenol IV, or to give an IV of normal saline and apply heat to the stinger site. These actions do not address the allergic reaction. A client phones the telehealth nurse reporting nausea and developing of a throbbing headache while on hiking in the mountains. Which teaching will the nurse provide first? A. Rest to regain strength. B. Drink water to rehydrate. C. Descend to a lower altitude. Or D. Take acetaminophen if available. Correct answer is C. The best treatment for altitude sickness is the first descent to a lower altitude. Once that has been accomplished, the client can rest, can drink water, and take the acetaminophen if available.